So the pelvic floor can mean different things to different people, but in essence it represents a hammock or a trampoline, if you like, of muscle, tendon and bone that acts to support the structures in the abdominal cavity above the pelvis, and also acts as a gatekeeper, as a control mechanism of the structures that traverse through it. So in men that would be the waterworks and the bowel, and in ladies those two structures as well as the vagina. And so treatment and therapies towards the pelvic floor have a great impact on functionality because of the control that the pelvic floor has on these structures. So pelvic floor surgery are operative techniques that address damage or injury to the pelvic floor. We talked a moment ago about the role of the pelvic floor, which is one of support and one of controlling function. And so surgical procedures are directed at both those areas. So for example, if we are re-supporting the pelvic floor, we may consider operations from above through the abdominal cavity to help lift and reconfigure any weakness and collapse that may have occurred. We may think of operations to remove tissue that has slipped down and is causing a problem. Operations through the tail end to remove tissue, which may involve a stapling technique, might be an example of the same. We might think of operations to reinforce bulges that have developed through the collapse, through the weakness, and reconfigure the pelvic floor architecture in that way. So for example, a transvaginal repair of a rectocele would help straighten the rectum and help it function better. And the last category of surgery may be one to augment or to improve residual function that's already present in the pelvis. So, for example, sacral neural modulation, which is a technique of placing a wire into the nerve root in the lower back, may be used to augment and improve how the neurological function of the pelvic floor can be improved. We might consider bulking agents to help improve closure of the tail end and again augment the residual structure that's present. Pelvic floor can be injured through a variety of processes. The most common one is through childbirth. But other factors such as obesity, such as age, and inherent weakness within the tissue that you might see in hypermobility syndromes can all weaken the pelvic floor and can contribute to it collapsing and descending and malfunctioning because of that. There are important principles that we must adhere to whenever we see patients to present to us with problems with their pelvic floor. Any patient that has volunteered symptoms of a change in bowel habit, change in pattern of them going to the toilet, and especially if they tell us that there are other worrying symptoms associated with that, for example rectal bleeding, then it's incumbent on us to make sure that their presentation isn't one of some serious underlying bowel pathology such as a cancer, and we'll often treat patients along those lines first and foremost. In the absence of such a diagnosis, then the next part of treatment is a conservative, non-operative approach. We've already talked about the pelvic floor containing muscle and bone and tendons and have movement and function. And in that way, it's not dissimilar to a knee or a hip. And if we were to present with a painful knee or a poorly functioning hip, we wouldn't expect surgery as first-line therapy, and so is the case in the pelvic floor. The majority of our patients will see a pelvic floor physiotherapist or a nurse specialist that will help them improve their function, strength and their coordination of the pelvic floor, and these measures alone may improve function to a point where a patient needs nothing further doing. And in fact, 2/3 of patients are happy with conservative measures in isolation. It's only those patients in whom are resistant to conservative treatment do we consider ongoing investigation and possibly surgical remedies. When patients have exhausted non-operative treatments for their pelvic floor disorder, and if their symptoms are severe enough and life-changing enough to want treatment escalation, then we're in the realms of surgical therapies. What procedures we perform is very much dependent on clinical appraisal and on investigations, and they'll help us define and point to us where the problem, the main problem, is arising from. And that is what dictates what sort of surgery may be available to us. So, for example, if a patient has a prolapse and has a very weakened pelvic floor, we may consider options to re-support it from above and regain alignment in that way. And keyhole surgery might fall into that category. We may consider removing tissue that is herniating down into the pelvis and getting in the way and blocking bowel function, and operations through the tail end to remove that redundant tissue may be considered. And finally, we may think of therapies to reinforce, to improve the structures that we already have in place. And so, for example, if we have an incontinent patient that has a weakened sphincter, if there's no prolapse, we may consider operations to either rebuild that sphincter through an operation to overlap the residual muscle, or we may consider nerve stimulating techniques or bulking agents to try and reinforce the tail end. The recovery from pelvic floor surgery is dependent on the type of procedure that's performed. But I think it's fair to say that even the larger operations, the reconstructive keyhole procedures, have a quick recovery associated with them. And most of the procedures that we perform for the pelvic floor are either day case or overnight stay. The immediate result of the procedures can be a little variable, especially if we have patients on laxatives to help the bowel open. And patients need to be warned that in the immediate post-operative period, how their bowel function may well not represent how it behaves longer term.